Hello, my name is Angela Zoe, and I am a first-year medical student at Creighton University School of Medicine in Phoenix. Today, I will be presenting a case of a man with von Hippel-Lindau syndrome, titled Man with Renal, Adrenal, and Intracranial Masses, and discussing the implications of this diagnosis. In our case, a 38-year-old healthy male presented to the hospital with complaints of sudden onset diffuse abdominal pain. CT scans showed multiple lesions in the pancreas, a right adrenal mass, and masses in the right kidney. Biopsies confirmed clear renal cell carcinoma in 2 of the renal masses and a pheochromocytoma of the right adrenal gland. CT angiogram of the head revealed multifocal hemangioblastomas. These findings are summarized in Table 1, and imaging and pathology are presented in Figure 1. The combination of renal cell carcinomas, pheochromocytoma, and hemangioblastomas was strongly suggestive of von Hippel-Lindau disease. The patient underwent Whipple pancreaticoduodenectomy, distal pancreatectomy and splenectomy, hepaticojejunostomy, gastrojejunostomy, and celiac and portal lymphadenectomy. Pathology confirmed a well-differentiated, low-grade pancreatic neuroendocrine tumor in the uncinate process. Multi-cancer genetic panel testing confirmed a known pathogenic VHL gene mutation, a 3 base pair deletion in exon 1 of the VHL gene. It was unclear if this mutation was de novo or familial, as no family testing was done, but the patient's father's death at an early age from pancreatic cancer suggested that it might be familial. Subsequent surveillance CT showed another hypervascular lesion of the left adrenal gland, which was concerning for a pheochromocytoma. Currently, the patient is being followed closely by multiple specialists and has been advised to continue close monitoring and surveillance. Von Hippel-Lindau syndrome is a rare autosomal dominant genetic disorder characterized by numerous benign and malignant tumors in multiple organs, such as retinal and cerebellar hemangioblastomas, pheochromocytomas, and renal cell carcinomas, as depicted in Figure 2. Other associated tumor types include paragangliomas, neuroendocrine pancreatic tumors, and endolymphatic sac tumors, as well as renal and pancreatic cysts. The VHL gene is a tumor suppressor gene on chromosome 3p, which modulates hypoxia-inducible transcription factor levels. The incidence of von Hippel-Lindau is 1 in 36,000, with 20% of cases arising from de novo mutations and 80% from inherited mutations. Manifestations of von Hippel-Lindau are highly variable, even within families and among those with the same pathogenic variant, so timely diagnosis and surveillance is important for prevention of tumor-related complications. This case demonstrates a few key takeaways about the diagnosis and management of von Hippel-Lindau syndrome. Those who present with 2 or more characteristic lesions, or with 1 lesion and a family history of von Hippel-Lindau, should be suspected of carrying a pathogenic VHL mutation. Identification of a heterozygous germline VHL pathogenic variant by molecular genetic testing establishes or confirms the diagnosis. The offspring of an individual with von Hippel-Lindau syndrome are at a 50% risk of inheriting the VHL pathogenic variant, and follow-up testing for family members should be considered. The clinical impacts of von Hippel-Lindau can be varied, and clinicians need to be aware of potential malignancies that can be seen. Clear renal cell carcinoma occurs in about 70% of affected individuals by age 60, and is a leading cause of mortality in von Hippel-Lindau syndrome. Recommended annual surveillance testing in von Hippel-Lindau carriers includes ophthalmologic and neurologic evaluations, imaging of the central nervous system and abdomen, and plasma and urine biochemistry. Thank you for listening to our case. I would be happy to answer any questions.